I'm Lynsey Freeburn. I'm the Paediatric Coordinator for NISTAR. So that's Northern Ireland Specialist Transfer and Retrieval Team, and it's neonates, adults and peds, a total team. Alright, so it's what we want, and to be honest, we want everything. We want everything done before we arrive so we can go in and pick them up and take them away and go as quick as possible. So I thought ideally we should start with a referral. So we're looking at, we want the person coming to the phone that actually really knows the patient. We don't want somebody that has just come on for the evening shift and they're not really doing anything, so they can go make the phone call. It's the person that knows the patient and give us all the details and be thorough and concise and sell the patient the best so that we'll say yes, we will accept it and we'll come and get it. So what we need is patient demographics, name, date of birth, current location of the patient, and we always like a wee weight for a wee drug dose calculator or for giving you any help with actually doing drug dosing. We want the relevant clinical history and a thorough examination, and you want to know what all's going on and get it detailed. And when the person is taking the call, they will be going through a sheet in front of them and they'll be going airway, breathing, and they want as much information as they can so that they can go to the consultant and sell it to the consultant, and then they can make the decisions. Also, it helps with them making a management plan. So what you've done to date, what response, and sort of what your parameters are at the minute, and you can work with the consultant on the phone and decide what you actually should have your parameters at and see what you need to get, and any blood results. If we can give advice over the phone, so it can be that we don't actually accept the patient, but we can give advice, and you can then phone back if things change and we can reassess and give further advice, or we can give advice and say yes, we've accepted the call and that the retrieval team is going to come and pick up the patient. What I would say is please do not delay any urgent treatment or interventions while waiting on the patient when you're waiting on the retrieval team. So if we have advised intubate, head to the area that you need to head to. Each hospital, it may be somewhere different. It can be theatre, it can be stay in A&E, it can be moved to an adult ICU. So it's just moved to where that area has decided the critical care retrieval needs to be intubated in. So head there, and again, update the team if you've moved so that we know exactly where we're going when we're arriving into the hospital. Induction agents, and that can be discussed with the team, and as you say, there is a variety of induction agents and each one likes their different drugs, so discuss it with the consultant. Depending on their condition, they can give you advice about the best drugs to give. Ensure the ET tube is well secured. Carolyn done a good job of teaching you all how to tape them, so hopefully they'll be perfect next time. I wouldn't advise to give them a good tug to see if they're in place, just nice and neat and tidy. Do not use pre-cut tubes. You run into issues. If you pre-cut them, if you haven't got it in far enough, you've no more tubes, so you may have to re-intubate them. So don't cut them. We may cut them when we arrive to get rid of dead space, but we'll have checked x-rays and that as well. Gastric tube on free drainage for all ventilated patients. Just helps with ventilation big style, and also means that in the back of the ambulance you're not going to have anybody being sick, and we really don't appreciate that. And I would say put the gastric tube in before you get your x-ray, because it just helps that you can see it's in place, and that way you're doing your ET tube and your gastric tube at the same time. You don't need a second one. And just remember about any cervical spinal mobilisation for any trauma cases, so just think about that before you start moving the neck about to put a tube in. Breathing wise, ensure adequate ventilation. Again, that can be in theatres on an anaesthetic machine. Again, dead space on those is massive, so do speak to the transport team or the PICU consultant if you're having issues with ventilation. Can be on a transport ventilator in an A&E, and most DGHs will have some mode to ventilate the kids as they go. End-tidal CO2 throughout always keeps an eye that your tube is in place, and it means that you're able to keep an eye on how your CO2 is, and that way you can actually see if you're doing a good job with your oxygenation and your CO2 is low. And blood gases. Again, blood gases, you can do capillary blood gases and we can work with them. Don't have to put in an art line, that can be further down the line or not at all. Ventilate and troubleshoot. So we've already done dopes. So display tube, check the end tile, exact length of the tube, make sure you can have a look at the tube. Some people tape the whole way up the tube and you can't see the numbers. So it's always worth not taping the whole way up so you can keep an eye on the numbers and know if it's actually moved in or out. Again, it can be in too far or it can actually be out. Obstruction, take off, bag, use your suction. Make sure that your suction tube passes to the end of the tube. You're going to check how far you've suctioned in. Make sure that you have got down. If you're having any issues, you can do a saline suction, see if you can displace anything, or at the end of it all, you may need to change tube. Pneumothorax, so you're thinking about chest x-ray, bedside, ultrasound, and they have all done that earlier on, so we're not going to go down that route. Equipment, check your ventilation settings, and again, this is all to do with your dead space and making sure that you've got the paediatric tubing on or the neonatal tubing on. Every ventilator has lots of different tubes, and anaesthetic machines have lots of dead space in them. So if you're coming into any difficulties, again, I would say phone the consultant or the transport team and have a chat and see if they can help you or assist with that. Also large leaks, if you haven't inflated your cuff properly or if you haven't put a cuff tube in, you may have issues with your ventilation that way. Stomach, ensure that it's decompressed with a gastric tube. Circulation wise, we would ideally like 2 well secured lines. I know that might be difficult. Normally we have regular repeat offenders, so they have been well stabbed and well poked, so try your best. If you're having any issues with a shock patient, just move on to IO, and then once you've got fluid on board, you can go back and try for another peripheral of that. Central line, we would say if you're thinking that you're heading towards inotropes, so that if your DGH is happy to do them, bigger patients will be happier, you can move on ahead and put in a central line. Arterial line would be pretty similar to central line. If you're needing inotropes, it's always handy to have one in. Other than that, remember just to keep doing regular cuff BBs, and you can set that cycling so that it just continuously goes and it'll flash up if it's going low. If the child is shocked, please keep going with ongoing resus, or if things change, do phone us and get advice if you need any further input. And if you need any help with the inotropes, that all of the transport guys are great at, guys and girls, sorry Julie. So they're all great, they've got their capes on, so they're great at giving advice, inotrope advice, push dose. They will give you that all over the phone and make things as easy as possible. And just remember, you can run your peripheral adrenaline, but again, it's a different dose, so do check. I've said phone PICU if you're having any issues. Shock neonates, consider your cardiac conditions, so do femoral pulses and go with your 4-limb BPs, and just always think ahead of that. So ensure that you've got adequate sedation, muscle relaxant. We will give advice. Normally it's morphine and midazolam in lovely 50 ml syringes, and all of these are on the drug dose calculators that lots of teams have. So no matter if you're Belfast, if you're Northern Ireland or outside it, most teams have a drug dose calculator, and it will tell you exactly what to put in the syringe and what your ranges are to run it at. But again, any issues, if you can't find it, I know it is a stressful place, do give a phone and we will give advice over the phone, and hopefully it will help. Pupils, keep checking regularly, and again, that's for any child, and it's a good way of checking if your actual sedation is working well. Again, I've put the C-spine, so just make sure that you've mobilised your C-spine here. And monitor your glucose, especially in the wee neonates. Patient temperature wise, we aim for normothermia, unless cooling is indicated. And again, I've wrote there about neonates, ideally they should be in an incubator with a temperature probe on to keep them within a normal range. And consider your antibiotic cover. Fluids wise, so again, on transport, we like everything in 50 ml syringes so that we can put them straight into our syringe drivers and get out of there as quickly as possible. So draw up maintenance fluids. Normal in 5 is normally quite appropriate, but you can go by your gases, and normal in 10 in the neonates. Make sure syringes are well labelled and signed. It's just whenever they get to PICU, they'll love to double check them. So make sure they're well signed so that we know exactly what's in them, And for like sedation and that, it's well signed so that we know what we're bolusing when we're bolusing it. I say consider urinary catheter. Do consider it, because nobody likes a wet ambulance. Or do put a nappy or a pad on them, just to make it as easy as possible. Documentation, so be prepared to hand over when we arrive. Don't disappear. Make sure that somebody's there and one person hands over. Update the family throughout, and make sure that they know where they're going, and that they're happy about what all's going on, because it's very confusing for them. Why does their child have to leave? You're doing a good job, but just explaining to them exactly why, where they're going. There may be a chance for them to travel in the ambulance, but again, that depends on the child's condition, whether or not we've got people like training with us, and what ambulance we're actually using, because if we use a frontline, we're down a seat. So it's just that you say that there may be a chance that they can travel. There's lots of things online, parent information leaflets on NISTAR webpage, and other teams, no matter where you are, will have parent information leaflets, and it just gives the parents an idea of exactly how things go, and it gives them a chance to give feedback. Transfer letter with all the history on it. Photocopy notes, recent blood investigations. We can get the x-rays and all that. We can normally have seen them before we even set out. Fluid and drug charts. Ideally, I would say send the original with the transfer team. You photocopy way in advance, and then you give a load of drugs in between, and they can be put onto the photocopy. So I would say, do send the original, leave the photocopy back at home. Highlight any social or safeguarding issues, and it's always good to get that right at the start before we offer a seat in the back of the ambulance as well. Nobody really wants an irate person in the back of the ambulance. And for babies under 1 month, consider maternal sample for cross match, just in case they're surgical or the septic needs a blood transfusion. When the team arrives, we should introduce ourselves. Quite a lot of people now know all the consultants and the nurses, so they won't introduce themselves, but if the family's about, make sure that we introduce ourselves and say hello. We'll normally go and wash our hands somewhere for the neonatal unit ones. We'll go and find a sink and make a point of it right in front of them. Wash hands, put the gel on, get our apron on, and we're very good at that. So we'll get a thorough handover. Again, we would say that we want one person handing over. We don't want one person handing over here to one person handing over there to another one. We want just one person handing over, and a thorough, A, B, C, get through it all. We then will assess the patient, make our plan of what we're going to do. It may be nothing, because you have done everything and we're ready to go. It may be that we need to stay and play a bit, maybe put lines in, start other infusions. But again, depends on the child. We'll review the documentation, make sure that we've got everything, and then we'll prepare the patient for transfer. So we'll attach up our monitoring, check the ET tube, check our x-ray, make sure that it's in a good position. We'll check our IV lines, make sure that they all work, make sure that they're well secured, but we would have all the, the tubey grip and the dressings off the top of them. The kids are not going to actually move too far, so if you take that all off so you can see throughout that everything is going in. So all lines are working. We will check all infusions, and we will double check exactly what doses are in them, so that we, like I said earlier, that we will know exactly what we're bolusing if we're bolusing in the back of the ambulance. And we'll swap them onto the transport pumps. We'll put the patient on to whatever ventilator we've decided, and we may wait 15-20 minutes, but depending on where we're starting, we may do that right at the start, so by this point we're ready to get wee blood gas. We will transfer onto the trolley, secure in a 5-point harness, and make sure all equipment is secured on the trolley, and all the trolleys are very good. Mark will show you later on the critical care trolleys, and ours is pretty much set up like that, so everything is attachable below the trolley. We will update the parents, and we will discuss travel arrangements, whether or not they can come with us. And again, hopefully they can. I just want to say all the DGHs in Northern Ireland are doing a fabulous job, and you do make life easier for us, and we do appreciate everything that you do. And so keep doing it. Any questions?